we're going to basically have the Nexus head CT rule versus the Canadian C-spine rule. A lot of you guys probably use Nexus. Many of you probably don't use the Canadian C-spine rule. So what we're going to do is go back and forth. Each of them are going to have 3 minutes to make their case. So we'll start with Nexus, because forget him, Canada, you know. Yeah. And then he'll have 3 minutes. Then the Canadian folks will have 3 minutes to open. Then Nexus will get to rebut. And then the Canadian C-spine will have the last. At the end, we'll basically vote by applause about who you think made the more compelling argument for their rule being the one that you should use. Okay?
I'm going to start with the Nexus paper. So the purpose of the study was clinicians obviously fear missing occult cervical spine fractures. So the authors of the study realized this is a justified fear. So they wanted to develop a decision instrument to help clinicians reduce the number of unnecessary cervical spine films in blunt trauma patients. So they developed a huge, well thought out study. It's a prospective observational study that was performed at 21 centers across the U.S. So these centers were a variety of different types of centers, so large academic programs with residencies to small community hospitals without residency programs and everything in between. So 34,000 patients were used in the study, this huge study, and their decision instrument included the 5 Nexus criteria that we all know. So the decision instrument is five criteria, and those are no cervical, midline cervical tenderness, no focal neurodeficits, normal alertness / no ultramental status, no intoxication, and no painful or distracting injury. So people who met this criteria were classified as low risks. So every patient in the study got a 3-view study of the C-spine. So that was a lateral, anterior, posterior, and an open mouth view of the odontoid, unless a CT or MRI was taken. So a list of clinically significant C-spine injuries was provided by the study, and in order to determine the sensitivity within 0.5, at least 737 patients with cervical spine injury were actually needed to allow the study to have statistical significance. So they defined a true positive in the study as patients that did not meet one of the decision criteria and had a clinically significant C-spine injury. False negative was a patient who did not meet one or more of the 5 criteria and who had a radiographically documented injury. So the results of the study, they ended up finding 818 patients with cervical spine injuries. Of those, 65% were male, so we're obviously predisposed to doing crazy things and getting injuries. The average age was 40, and there were only 8 individuals who presented as false negatives. So these are the patients who did not meet one or more of the 5 criteria and who had radiographically documented injuries. So 2 of these actually had clinically significant injuries. So 6 had cervical spine injuries, but they weren't classified as clinically significant, meaning that there wasn't a surgical or treatment intervention for those patients. So the overall rate of missed cervical injuries was less than 1 in 4,000 if using the Nexus criteria properly. So they figured this adds up to an ED physician seeing 1 occult C-spine injury in 125 years of practice.
So that's our intro, telling us a little bit about Nexus. Got a few minutes for Team Canada, complete with the scar.
All right, so Canadian C-spine rule was essentially developed in reaction to the Nexus criteria, because the idea of Nexus criteria was to decrease the number of radiographs taken on low-risk spinal injuries in people's like a GCS of 15, and they thought that Nexus may actually, despite possibly decreasing the rate of C-spine radiographs in the U.S. by like 12% or something, it would increase the rate of radiographs in the rest of the world entirely. So they did this derivation study that was also multi-center, not to be outdone. 20 standardized clinical findings were evaluated at 10 large ED and community hospitals. However, the sample size was much smaller, about 8,900. There were actually 12,000 eligible, but 3,000 weren't enrolled. It seemed to be about the same number of patients, except for had more severe injuries, so would have got irradiated anyways. Some significant differences, though, is that it excluded anyone younger than 16, whereas Nexus actually included people down to the age of like 2 or 1. And also, it was a derivation study rather than using a body of literature beforehand with 5 preset criteria. Also, not everyone, whereas in the Nexus study, everyone got radiographs. In Canada, they don't pull the trigger quite as quickly. Nexus evaluated everyone who had a radiograph, where Canada included a bunch of people who went home and had a nurse call them 14 days later and ask them about any symptoms they could possibly still be having. This apparently was had been validated in a prior study, and none of those candidates had any symptoms. There were also some more stringent inclusion criteria, rather than just the everyone who got radiographed like in the Nexus. However, similarly, radiography was ordered at the clinician's discretion. Overall results were 68.9% of these patients underwent a C-spine radiograph, and 31% underwent the structured 14-day telephone follow-up. 151 had clinically important C-spine injuries, and none of the later contacted patients had a significant injury. The goal was similar to the Nexus. The primary outcome is you don't want to miss any of these catastrophic injuries, so they shot for a sensitivity of 100% or more realistically 99.5, and specificity was the secondary outcome. You want to decrease the number of people who were getting these radiographs and conserve healthcare resources. Their rule was significantly more convoluted than the Nexus. It's just not 5 simple criteria. It's a 3-step algorithm that was derived from the findings of the study to create a rule. Those are like step 1 is the first question: are they greater than 65 years old? Do they have a dangerous mechanism? Do they have paresthesia in their extremities? If they have any of the above, they get a radiograph. Do you have any low-risk factors which allow safe range of motion assessment, which is a simple rear-ended MVC, sitting position ED, ambulatory at any time, delayed onset of neck pain, absence of midline C-spine tenderness, also in the Nexus. If they answer yes to all those, you can move on. If not, you get a radiograph. And the third one is just, can they turn their head 45 degrees either way? And if so, they don't need a radiograph. Anything else to add to that?
I'll give US the top.
And it was later evaluated in a prospective study which replicated these results, and we'll save the rest.
All right. So kicking it back over to Team America. No pressure at all. Don't. Jerry Hoffman is America as far as I'm relevant.
So I bet a lot of you.
So tell us why you think you're South Africa.
Can anyone rename everything that was in the included in that study? No. Okay. So it's way too complicated. I mean, we're busy in the emergency department, so the Nexus is great because it's a simple study that you can use to rule out these high-risk patients, or actually low-risk patients. So, for one thing, his study is Canadian, so how can we apply all these Canadian findings in America? It's difficult. And so not everyone in the study got a film. So how are they sure that they didn't miss injuries in Canada? I realized that these nurses called patients back, but we're still not sure of all of the simple fractures that were missed. And while those might not be clinically significant, they may still have been missed. There was also a significantly smaller population size in the Canadian. There's also a limited age range, 16 to 65. So if you're in Canada, they don't care about kids' C-spine injuries, I guess. So Americans love kids. I don't know about Canadians. It's significantly more convoluted. With Nexus, you only have to know the 5 criteria. The Nexus has a low specificity and positive predictive value, but that's not what the study was created for. It was created to evaluate patients that didn't need imaging. So if a patient's low risk and they meet the criteria, these patients can avoid imaging. The study was really created for American ERs because we image way too many people. So if you can use this criteria to safely rule out certain individuals from needing cervical spine films, the study is effectively doing what it was created to do.
Team Canada.
All right, so begin rebuttal. First off, my colleague's point was that this is far too difficult for anyone to do. Which here's a small card, has everything you need. You can put it in your pocket. Second idea is this has actually been tested a bit in a head-to-head study that showed that the Nexus missed 16 significant injuries versus 1 in the Canadian study. They then blamed this on the Nexus was too hard and too subjective to where clinicians couldn't decide what a significant injury was or whether someone was really intoxicated or not. And that it was essentially too difficult to use. So despite following this more rigid criteria, they just couldn't agree on it. However, then to further the point and further embarrass Nexus, they started training triage nurses and paramedics to use the Canadian CT spine rules. They showed in studies that they could do it just as effectively as a physician, mostly because the card actually gives you an algorithm with specific comments and specific points. So you can then treat this as a force multiplier to where people are off of backboards and C-spine neck collars that can cause damage as well before they even arrive in a crowded ER and sit for hours in America. Second thing is missed injuries. I believe we talked about that they were not clinically that we might be missing non-clinically significant injuries. Who cares? They're not clinically significant. Nobody cares if you miss a little something that's going to heal on its own. Also, with the 14-day follow-up, that's been proven multiple times to not miss clinically significant injuries, so people are fine. Next thing is peds. We're not evaluating the right age populations. Pediatric patients are different. I think most people would agree with this. That's why we use PCARN rather than something else. I don't know, whatever we use in adults. But I think that kids aren't little adults and they need different C-spine rules. Additionally, greater than 65, Nexus has been devalidated in 2 separate studies. And Nexus cannot be applied to adults greater than the age of 65 either. So there are the points there. Additionally, in a head-to-head study, the sensitivity and specificity for the Canadian C-spine was decided to be higher. I've got the numbers. It was like 42 versus 35. However, the primary outcome is supposed to be not to miss catastrophic neck injuries, which they're essentially equivalent on. It's just there's a secondary outcome as well to try to conserve resources and act as a sort of steward for what we have in our gross overspending, which the Canadian, though there are some methodological flaws, has been significantly more specific and decreases rates of, or is thought to decrease rates of C-spine injury more greatly than the Nexus. However, there have been some arguments on it, but there's a possibility of it doing better. One of those arguments was that there are misclassification errors with the Nexus that we talked about earlier, to where physicians can't agree on the types of whether there's a significant distracting injury or not. There's also, yeah.
Well, we'll give you 30 seconds
I'm
just
sorry,
so you can
man.
chime in.
I try to. So bottom line is the purpose of this clinical diagnostic rule is we try to decrease the inefficient radiography for non-clinical relevant, like alert, blunt, and awake patients. So as the data my colleague is just talking about is, I think our concern about Nexus is actually we are concerned about increasing the number of radiography, non-relevant radiography, because distracting injury in one of your diagnostic tool is toe. If some people just like their toe injuries have some like a rare-ended car accident, and you have to scan it by your rule. And then my concern is going to increase the radiography.
All right, guys. So now time to vote. So the question is, which rule do you think is more clinically useful? Okay, or a shortened way. If you can only have one of these 2 rules, which one would you rather have, based on just what these gentlemen presented today? Not based on what you actually use, but just on what they did today. So let's hear it for Nexus. Let's hear it for Canadian C-spine. Wow. All right. So I think Nexus narrowly wins it. So we'll just have a couple minutes of discussion. I think both groups did a really good job presenting this. Let's give them all a round of applause. So I'll tell you what I personally do. I apply Nexus first and then Canadian C-spine rule if they're Nexus positive, because I hate scanning people. I think X-rays in the adult population is probably a dinosaur that needs to go away. It just misses too many people, in my humble opinion. Kids is probably a different story, where maybe you can get away with plain films more often. But C-spine injuries in kids is pretty rare, to be honest. And if you're not careful, you'll end up scanning a whole lot of kids. If you get x-rays that aren't perfect, yada, yada. So if their Nexus is positive, then I'll apply the Canadian C-spine rule. And if that's okay, then I will be okay not imaging them at all. And that's just my practice. Does other people have? Almost always. There is a narrow subset, particularly of young women. I don't want to irradiate their thyroid, where I will sometimes get a plain film. But almost always, if I have any actual suspicion of a C-spine injury, I'm going to actually just get a CT to start with. Valid?
I think the determination of what is low risk can be challenging for some people. So if you blend both of those things and use the Canadian C-spine risk mechanism of injury component along with the Nexus criteria, then you can find something that's actually useful. You should also look at some of the trauma literature to see exactly what they say to do, which is just that. They also say that C-spine plain films are pretty much worthless now, unless you're doing it to treat the mind of the patient. If you really want to image somebody, image them once and scan them.
So I think I'm pretty close to Mike there. That I mean, plain films in some series have missed the majority of injuries, which is a terrifyingly disappointing performance. A good number of them were. Some of them were not unstable injuries, but they actually do miss with surprising regularity. And then all too often it's disappointing that they're not technically adequate. The Nexus criteria had really, really touchy. You got to see all of C7 to T1. And frankly, we just don't get that in our overly fat adult populations. Like, it's just really, really hard. And honestly, the radiology techs also don't get enough practice with doing plain films in adults to reliably get you that beautiful odontoid that you really want to see and so forth. So particularly if you get a rear end crash with midline neck pain and that's it, strongly consider using the Canadian rule and not getting any pictures.